And welcome to ICE webinars. Today we are joined by Dr. Karim S Karim, co-founder and Chief Technology Officer at KA Imaging. ICE webinars would like to thank our sponsor, KA Imaging. KA Imaging designs, manufactures and sells unique X-ray imaging detectors and mobile systems that leverage cutting-edge spectral and phase contrast X-ray technologies for medical, industrial, veterinary, non-destructive and scientific imaging applications. KA Imaging's core technologies are protected by 81 global patents, and among other notable accomplishments, the company's Reveal 35C detector was used to take the first medical X-ray in space in April 2025. Great, that is. So for more information, visit kaimaging.com. Now, just a quick reminder to save the date for our 2026 ICE Expo, which will take place at the San Antonio Marriott River Center in Texas. So that's February the 20th to the 22nd. Now, the Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, radiology technologists, and imaging engineers. ICE offers valuable CE credits from the ASRT and ACI and is a unique community of key decision makers and influential imaging professionals. So for more information about the Expo, please visit attendice.com. Okay, today's webinar is eligible for one ARRT Category A CE credit by the AHRA, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your one CE credit, and you'll be able to download the certificate directly from your computer once you've submitted the survey. Now, if you have any questions, you can reach us at webinar@mdpublishing.com. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on your dashboard. Let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. As we all know, October is Breast Cancer Awareness Month, so what colour ribbon is associated mostly with breast cancer awareness? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, our presenter today is Karim S Karim, and he will be discussing SpectralDR dual energy X-ray, clinical and operational impacts. So Karim, you may begin whenever you're ready.
Well, thank you so much for that kind intro, and really happy to be here. As was noted in the intro, SpectralDR, this is something we've talked about in the past, but one of the most notable achievements this year was it actually went to space as the first X-ray in space. One of the reasons why it was interesting for space is one of the research applications is direct measurement of bone density from the X-ray. And so with a chest X-ray, you could, in theory, get a BMD value like DEXA would give you. So that, of course, is very important for astronauts who are trying to keep track of their bone density in a low gravity environment where they tend to lose bone density quite frequently. Okay, so today's webinar is not going to be focusing on bone density. It is rather going to be focusing on more applications on Earth, and we'll talk about some clinical and operational impacts. So today we're going to look at just a review of what's single exposure dual energy subtraction, or SpectralDR. We're going to look at what were the limitations of the older generation dual exposure dual energy solutions, and why that limited or hindered their adoption. And then we'll also show how SpectralDR can overcome those limitations. We'll talk about some clinical use cases where very exciting ones where SpectralDR in the past 12 to 18 months has really demonstrated an edge in clinical sites. We'll talk about some of the hospital implementations of SpectralDR, and then we'll also go through a little bit of health economics to see what the impact could be for a hospital or a clinic to adopt SpectralDR. How is that going to change your operations? How is that going to change your financial bottom line, or top line, rather, as it may be? Okay, so just as a bit of background, the main drawback of X-ray is you can't tell the difference between materials. It shows shape really nicely, like you can see on this image right here, You can see that there's a pacemaker, you can see there's a portacath, obviously the ribs and the soft tissue, the heart, all shown there, but you can't really tell what's what other than by recognizing the shape. Like, oh, I know this is the heart, I know this looks like a portacath. That's kind of, you know, what X-ray is. What if you could subtract all the materials that had an atomic number of 20 and higher? In that case, calcium, which is the main component of bones, would disappear. The portacath, which is typically made of metals, would also disappear, and that would leave only the soft tissue or water-containing material behind, and maybe a bit of the plastic from the portacath. What's interesting in this image is when the pacemaker disappears, you realize that there is a mass, a lesion that was superimposed on the pacemaker, and that would have been completely missed with the conventional X-ray, with or without AI helping you. Because that type of information doesn't actually exist in a conventional X-ray. So this is herein is the attraction of dual energy subtraction or even SpectralDR, and this is what we're going to talk about today. So SpectralDR is the world's first FDA and EU MDR cleared dual energy X-ray detector. It's also Health Canada cleared and in about 8 other countries worldwide. It can be used both in fixed and mobile applications. What makes it unique is a 3-layer design, a triple layer. And this detector uses those 3 layers to overcome the limitations of other older dual energy technologies. The nice thing about this detector is it can capture a conventional X-ray, a bone window, and a soft tissue window. And we'll get into what that is in a single exposure without any motion artifacts, with no change to clinical technique or operation. In that sense, it's a direct replacement for a conventional X-ray because it doesn't hurt you. You only get additional information which can help you. Now let's talk about a bit of a background, a little walk down physics lane or memory lane rather. So dual energy X-ray is 1970s technology. This is not new, right? Researchers in the 1970s were playing around with this idea because it has the potential to be more accurate than X-ray. And the reason is very simple. In an X-ray, the images are primarily qualitative for visualization. They highlight shapes or morphology. Dual energy X-ray, unlike X-ray, is quantitative and can highlight both shape and material information. For example, what you have on the right-hand side are 2 X-ray images that were taken, and one at a low energy, one at a high energy, and then a material subtraction algorithm is run based on linear attenuation coefficients. And what results is you get an image with no calcium, and then you get another image with no water. The no calcium image is called the soft tissue image. The no water image is called the hard tissue image, or bone window, if you will. What's important here is the quantitative element. There's no calcium in the soft tissue image. In general, most of the calcium has been subtracted out. And in the hard tissue image, the water has been subtracted out. So all the most of the heart, the lungs, all of that gets removed. So that really means you're getting an additional bit of information. In the X-ray, you get the shape. But with the soft tissue image, what you're seeing is soft tissue. So if you see a mass in the soft tissue image, it's a soft tissue mass. If you see a mass in the hard tissue image, you're pretty sure that's a calcified something or the other, a calcified nodule or whatever. So that's how you get this additional quantitative information that allows you to do more than a regular X-ray. Okay. How does all of it work? What's the physics behind it? It's very simple. Bone containing calcium, soft tissue containing water, they both have different attenuation coefficients with X-ray. For example, at 40 kV, you can see what the mass attenuation coefficient is for water and for calcium. If you look at a higher energy like 100 keV, you notice that those coefficients have changed, although they're still slightly separate. If you take a contrast agent like iodine, you've still got the same type of, it's got one mass attenuation coefficient at 40 and another one at 120. So the idea here is that if I can get 2 samples, one at 60 and one at 120 hypothetically, of whatever the object is, in this case calcium and water, that's your human body, then I could, using a little bit of mathematics, extract which of the materials has calcium and water by just running a simultaneous equation. And that's really all that dual energy is. So here's an example of an object. This object is a soft tissue object, but inside the object we have placed some kind of a calcified body or an iodinated body. And so as the X-ray goes through the soft tissue and calcium, it will have a different attenuation. And if the X-ray just passes through the soft tissue, it's going to have a different attenuation. Well, those are going to be captured in the detector. And once we have those in the detector, we can now separate the energies either by using a different KV beam, which is what most people typically do, or using a multi-layer detector, which is what SpectralDR is. And we'll get into that in a sec. And so simply once you have those, you have that information, you can do this very simple weighted logarithmic subtraction between the bone and soft tissue, knowing what the attenuation coefficients of calcium and water are. And by that, you can get your bone window and soft tissue window. Now, how has this been done for the past 20-odd years? So most people use what's known as a dual exposure, dual energy, and it's either a energy switching, a KV switching, or a filter switching. There's a couple of manufacturers in the market, each trying one or the other. The key point here is that they're using two exposures, not one, and they're using a single detector, a conventional flat panel detector. The problem with this approach is that you've got two exposures. So your radiation levels in general are going to be higher. You're going to need a grid because there's all sorts of problems with these images if you don't use a grid in the subtraction. And the other problem is there's a time delay between the two samples, and that leads to a motion artifact because you can tell a patient to stop breathing, but you can't get them to stop their heart. Their heart's going to keep moving. So those motion artifacts are very common, and those are, you know, it adds to all sorts of problems. And so to summarize the problems with dual exposure, dual energy, you've got higher radiation, because typically two exposures leads to that. Your equipment is going to be a little more pricey because the X-ray source needs to be able to switch between two energies, or there's some kind of a filter wheel that is switching in there, and some mechanical component is going to be more susceptible to repairs. The equipment is bulky. Typically, these are only done to date in a fixed room. Nobody has actually been able to do dual exposure, dual energy in medicine in a portable solution. So it's not really a portable option, it's a fixed option, and the images are susceptible to motion artifact. So the problem primarily though is that dual exposure, dual energy, because of its disadvantages, it can't really replace X-ray. It's usually proposed as an additional modality to X-ray, but then of course it runs into all sorts of problems. Is why do I want to give my patient extra exposure? Why don't I just do a CT if the X-ray is non-conclusive? Now, maybe about 15 years back, bone suppression software became a thing as well. In this case, people tried to do dual energy, but they weren't really doing dual energy. What they did was a software algorithm that tried to identify where the bones are, and it tried to hide the bones and backfill it with some kind of texture that looked like the material you wanted to see. The problem is it's not dual energy, so it cannot do any material identification. All you can do is improve the visualization in some situations by hiding the bones, and that's where the Achilles heel sits. So the good news with this type of solution is it doesn't require an additional X-ray exposure, but the bad news is the use cases are quite limited, and it can also lead to an increase in false positives because, like I said, it doesn't do dual energy subtraction. It's just doing suppression. And so this type of solution, the bone suppression, will not work for laterals, won't work for obliques, extremities, KUB, pediatrics, spine, skull imaging, right? It's only useful for a limited set of cases like PA or AP. Even in the cases where you could use it, there was a University of Chicago study that showed bone suppression was finding maybe half as many nodules as dual energy. Bone suppression could not identify nodules as calcified or not, and that could result in some costly incidental findings, which is of course problematic. because you may go through all this trouble and find that there's nothing there. And then obviously there's no bone image to identify calcium because this is not dual energy subtraction. And so bone suppression solutions to date have not really been able to solve the key problem that you're running into for X-ray, which is a lack of material discrimination. Now, dual energy has evolved from what it used to be, this dual exposure bone suppression kind of solution, to SpectralDR. And the question you'd ask is, well, what makes SpectralDR so different? So SpectralDR is a 3-layer detector, okay? So there's 3 detectors that are stacked on top of each other, 3 sensors, if you will. When the X-ray passes through the object and strikes this detector, the first layer absorbs some of the X-ray and filters the beam, and so the rest of it goes into the second detector. Then the second detector absorbs a little more of that original X-ray that was filtered and filters the beam again, and then that last beam ends up into the 3rd layer. So each of the layers is absorbing some of the X-ray signal, but the average energy, if you will, being absorbed is different for the top layer. It's usually the low energy in the top layer versus the middle and the high, versus the middle and the bottom layer. Those layers typically get the higher energies, and you can see how the spectrum changes depending on the layer it's absorbed in. So what's important there is that we have, in a single exposure, collected an image with 3 different spectral characteristics, which allows us to do dual energy without requiring a second exposure. And the way we do it is we just take the signal from the 1st and the 3rd layers, and we can do a subtraction and generate the dual energy image just like in the past. And at the same time, we can add the signal from all 3 layers to generate the highest dose efficiency conventional X-ray image. And you know, often I get asked this question, you know, you went to 3 layers, why don't you do 2 layers? You know, like, wouldn't 2 layers do the job? The short answer is it's actually for reasons of performance that we don't do 2 layers. People tried 2 layers for about 20 years. Usually what happens is you need to introduce a piece of copper in between the top and the bottom layer to get sufficient spectral separation. And because of that, you lose about half your incident signal. So of course your dose efficiency goes down, and now you've created a higher dose technique that is not going to be a replacement for X-ray. People have tried solutions without the copper mid filter, but even those require increased radiation, and they are very limited in technique. For example, you may need to use 125 kV every time. So if you had a pediatric case, or if you had like something like an abdomen or a skull or a spine or something where you wanted to change the technique to like 80 or 90, it's not going to work. Whereas with triple energy, you can use it for all of those clinical techniques because of its inherent efficiency and dose, which of course the 2-layer does not have. So this is just an example of the dose efficiency of the triple layer versus a conventional single layer detector. You're looking at somewhere up to even 30% improvement in detective quantum efficiency. The funny thing is, most people don't realize conventional detectors are wasting about 50 to 60% of the incident radiation. It just passes out the back of the detector, or it gets absorbed in a piece of lead that's hiding inside the detector. So where the spectral triple layer detector becomes useful is the 3 layers with 3 scintillators absorb a lot more of the signal, so we can easily improve the quantum efficiency. And as I said earlier, because it works like a conventional X-ray, you can use the same X-ray sources, you can use the same X-ray techniques. Even if you wanted to use a 70 kV technique, this device is going to give you the conventional image and the dual energy images without requiring a change to your X-ray dose. And obviously huge advantages for pediatric patients. Okay. The other thing I mentioned is that this is all acquired in a single exposure, and that's important because you get no motion artifact. So in this particular image, there are 4 images. The first 3 are taken with other commercial systems showing their motion artifact. The last one was taken with the SpectralDR system, and obviously there's no motion artifact because everything is acquired in a single exposure. There's the artifacts. And of course, remember I said you can do any technique that you could do with an X-ray with SpectralDR, and that's absolutely true. So in this case, you've got a bunch of laterals. You can see this is the calcium window of the lateral. Here's another calcium window. Here's some soft tissue windows. So you can see some very interesting pathology, and we'll get into more of that when we get into the clinical use cases. And then obviously SpectralDR can image all anatomy that X-ray can. So MSK is no issue. Sometimes you want to do that for a variety of reasons, like occult fractures, obliques, for, again, you know, specific use cases, but you can do pretty much any of the standard, you can follow your standard clinical technique chart. The other important point is that there's no extra time required to read the images as well. In multiple studies, we showed that the time to read the additional images actually goes down. So this is a huge benefit for the radiologist or the attending clinician who's reading the images, because the soft tissue window and the bone window allow you to make your decision quickly because of the additional information provided. Your overall reading time on an X-ray can even drop by 30%. So if I was to summarize what the benefits are for replacing conventional digital X-ray with SpectralDR, there's really three buckets. There's the quality bucket, there's the opportunistic finding bucket, and then there's the efficiency bucket. So when I talk about quality bucket, because you're going to find the problem early, you can now reduce potentially the 30-day readmission rates. This is important for ICUs and CCUs, especially when concerned with non-reimbursed procedures. Obviously, malpractice risk also starts to decrease. Opportunistic findings are really stuff you find that leads to a positive outcome for the patient, and obviously incremental additional revenue for the clinic. And so in this case, the big one is coronary arterial calcium, but also indeterminate pulmonary nodules. These are quite helpful. And then in terms of efficiency, because you can find the disease early, the problem early, you don't have to expend resources in staff having to move patients around the hospital. I'm specifically referring to things like ICU and CCU, where you have non-reimbursed procedures, and so moving patients around the hospital is just an added risk. Obviously, a decrease in time needed to read and interpret difficult X-rays, and better decision-making at the bedside, so the patient can get the right treatment at the right time. Now, let's do a quick review of some clinical use cases. So lots of clinical sites have actually used this device. Our big ones are the University Hospital Network in Toronto, Mass General Hospital in Boston, and more. So there's lots of published literature. If anyone's interested, just shoot me an email after this and I can send you along lots of published literature. What I'll talk about are just some of the images that have shown up through some of these studies, just to highlight the value. So I'll start off with the bedside X-ray use case. And so in this case, the obvious one is just making sure the lines and tubes are placed properly. That's of course very interesting. The other one is foreign bodies, like in post-surgical imaging. You want to make sure that nothing was left behind, like sponges and whatnot. So the bone window, because it highlights high atomic number materials, is really good for that. Things like pneumonia, pneumothorax, pulmonary edema, very common complications post recovery in the CCU, but also in the ICU. So if you can find these without having to move the patient to around the hospital to a CT, then this can lead to improved outcomes both for the patient and for the hospital. So this was a talk that was given by one of our clinical sites. Dr. Venkatesh, he's from Grand River Hospital in Kitchener, was the primary on this one, and they used the SpectralDR in the ICU of a community hospital. And the idea behind it is the hospital is a mid-sized community hospital in Canada. Nothing very unusual about it. They've got about 3,500 staff, about 700 clinicians. And their point is that you get people coming into the ICU, and usually these patients, they're screened by chest radiography. I think they were running chest x-rays on these patients daily, sometimes twice a day. And the idea was that was their condition stable or was something changing? Like when they got intubated, did that accidentally cause a pneumothorax? Were they getting pneumonia, for example? Did they have edema of some sort because of some procedure and whatnot? So the idea was, if we were to use SpectralDR exclusively in an ICU, what benefits would we gain? And to explore the benefits, we had 10 radiologists and intensivists who reported on some qualitative key performance indicators and one quantitative key performance indicator. So qualitatively, it was, extremely well received. 17 respondents, 9 radiologists, 8 intensivists. The radiologists in general reported that there was no significant increase or the reading time was faster. They reported the image quality was better compared to standard imaging. The intensivists, half of them said that their confidence increased in diagnosis and time was reduced to potential intervention. And they thought that they diverted maybe 7 to 14% of cases away from follow-up CTs. However, we had a quantitative step in here where we were looking at how many cases were referred to CT from this particular ICU in the given period of the study. And it was roughly a 3-month study. And what we noticed is that the number of cases referred from the study decreased by up to almost 37% in some cases. It was compared to study periods in 3 months prior and 3 months of the year prior. And so definitely, we can debate if it was 37% or was it 30%, but the trend was downwards. And so they were quite excited. And one of these units is now in their facility and they're using it, I think, in their CCU. So definitely the benefit is increased diagnostic confidence for some intensivists and the potential to divert CT scans for cost savings. And we'll talk about that, the economic impact of that in a bit. Here are just some images that the docs liked. So this was a particularly tough patient, but when you look at the soft tissue image, what becomes obvious is that there's a bilateral cavitation. The soft tissue image brings that up. Obviously, the soft tissue image is a bit granular, and that's to be expected with dual energy because it's just a subtracted image. But the point is, it gives you an indication that can then allow you to do something else. Same thing on the lines and tubes. You can see better lines and tubes. Some more line and tube examples. Again, you can see how the bone window highlights the lines and tubes very nicely. Here I can zoom in a little bit there. Here's another interesting one. There's a pneumothorax in this one. In general, everyone can kind of see it. Anyone who's trained can see the pneumothorax. What pretty much every one of them missed is that there was a rib fracture that caused the pneumothorax. That's right here, that you can see in the bone image quite clearly. Now that you see where the rib fracture is, you could go back to the DR image and you can kind of see it here as well. But that one would have been easy to miss. And this is one of the advantages of this type of technology. The bone window can help you see occult rib fractures, hairline fractures, and whatnot. Here's another one. This one is just a consolidation. That consolidation just happens to be superimposed on a catheter, a little clip here, and you can see the cavitation much clearer in the soft tissue image. So that's one of the interesting things with this technology is that on a perfect body, no problems, you can do things quite well. But generally, when you have some kind of a catheter, portocath, line and tube, or something in there, then pathology can go missing. So being able to separate that is quite important. Here are some images on foreign bodies. Can you count the foreign bodies is the question, and I'll just jump straight to the zoomed in version. So here, for example, you can see the conventional X-ray, and you can kind of see the foreign bodies. They're not that difficult to pick up. You can see them, but if you had to count them, that could pose some issues. In the bone image, they are very easy to pick up. I mean, this is significantly easier. So this is where some opportunities for post-surgical imaging start to come about from a quality perspective. Here's another one. This one is hospital-acquired pneumonia. Here, I'll just show the image for a second. So in this case, you've got, this is just a conventional X-ray. It was read by 2 senior radiologists. It's a 51-year-old cancer patient. In fact, this image was taken in the cancer hospital. And what they missed, of course, was that there's a focal opacity sitting in the soft tissue image. It's visible now in the DR image, but initially, when you had the portocath right next to it, it was very easy to miss that. But in this image, of course, it's quite easy to catch it, and this was confirmed on a CT. Same thing with this one. This is another image from the same cancer hospital. You've got a patient with potentially some pneumonia, but the clinicians were very uncertain. When they looked at the soft tissue image, it changed their diagnosis, or their confidence rather. They went from a 1 out of 5 to a 5 out of 5 rating because they were able to see the pneumonias very clearly in the soft tissue image, and it was confirmed on CT as well. Now here's an interesting one. This was an image that was taken at Mass General, and it was I think an emerge, and they were looking for cardiac, and they weren't sure what they were getting. So what you see on the top is just a PA, but it's been zoomed in around the heart area, and then the bottom one is a lateral, also zoomed in on the heart. And then we switch to the bone window for the PA and the bone window for the lateral, and then you also get CT PA and CT lat. And what you see right away is in the bone window, the calcium is very visible. You can see it very clearly, and just like you can in CT. And so this led to an astonishing result. And this was actually verified in 2 sites, both at our University Hospital Network site and also at the Mass General site. The result was that dual energy X-ray outperformed standard X-ray in sensitivity by almost a factor of 2.5 and doubled the accuracy without affecting specificity or the positive predictive value. And so the conclusion was that the performance of the spectral X-ray was comparable to CT. A sensitivity of 72 versus 77 and an accuracy of 75.6 versus 80. And this was in multiple studies, as I said. And so that leads to some really interesting possibilities in early detection or opportunistic detection, if you will. And that's kind of something that was said in some of these studies. Let me give you some more examples of that coronary calcium. Here's a lateral. Most people look at this and read this as a normal. When the bone image is provided, it becomes kind of clear that there is something here in the coronary arch, and that is, of course, calcium. So calcified coronary vessels were seen here as well. This was, I think these images were taken from the Canadian site. Here's another one, same kind of scenario. You can look at the soft tissue image quite clearly, but when you swing over to the bone image, you can see the stents that are sitting there. So again, this device has some interesting use cases, post-cardiac imaging, for example, in the CCU, and to be able to find this kind of stent. Just a few more images, and then I'll get on to the economic side. Here's a great image. It's a standard chest X-ray. Clinician with over 20 years of experience read it as a normal. Upon review of the soft tissue image, discovered that there was a lesion that was missed because it was right between the rib and the bone behind. And that's, of course, a really good example of an opportunistic finding, because that lesion is a soft tissue lesion. It does not show up in the bone image. It only shows up in the soft tissue image. It is definitely cancer, so that needs treatment. But the other nice incidental finding, if you will, was that an occult old rib fracture was seen in the bone image. And this, of course, if you stare very long at this part, you might see it. but it's pretty easy to miss. You're not going to catch that. But in the bone image, it's actually pretty easy to catch. So just a bit more evidence about occult fractures. But in this case, really a nice opportunistic finding of the cancer. Here's another one, same kind of story, a lateral image of the patient. Something's happening here at this joint. Most people read it as a calcified joint, but in reality, it was a calcified joint with a mass superimposed on top of it, and this was confirmed on a CT. So again, a beautiful opportunistic finding. Okay, so that kind of gets through our clinical piece, and now let's talk a little bit about operational and financial impact. So I mentioned it from the operational side. Really, this is a replacement for your conventional X-ray. There's no real change in technique or training your radiologist or training your radiology technician or any of those people. The workflow is almost identical, except you get 3 images instead of 1. So the real impact then is on the financial side. And what I mean by that is, let's consider, for example, the intensive care or cardiac care application, just as a specific application. So the value proposition here is that you would get higher quality and reduced risk, because you're finding pneumothorax, you're finding pulmonary edema, you're finding pneumonias early. And because you find them early, then you're not having to do these non-reimbursed procedures like recovering from pneumothorax, or alternately moving the patient around for follow-up CTs, especially if you can make the diagnosis at the bedside. Those follow-up CTs for ICU patients in Canada and the US at least are not reimbursed. So this calculation that I'm going to show you was based on data that we got from the Grand River Health Economic Study, and we developed a return on investment calculator. It's the ICU return on investment calculator. So let me pull that up. Yeah, so here is an example of this calculator. So the way it works is, and this is really just for informational purposes to give you a sense of how this could work. Obviously, you would use it to model your own site more precisely. We have some assumptions here that you can play with to make it more accurate to your use case, but this is really just for informational purposes. So for example, in this case, for an ICU bed that has, 20 beds, over the course of a year, you're going to save about 225 CT scans based on that 37% reduction figure that we saw in our health economic study. And that could lead to follow-up CT scan cost reduction of maybe 270,000. Now, if those CTs were opened up for outpatients, you could generate over $200,000 in revenue from billable procedures. Labor efficiencies, you don't have to have staff moving these patients around for CT scans, especially when it's not reimbursed. You can reduce repeat x-rays as well because you get the right answer the first time. You may potentially shorten your ICU stay, and this is something that you could measure yourself to see exactly how much that works out to be. And then the other ancillary benefits that are sometimes not quantified are, well, you're not moving patients around the hospital as much, so how many falls is that going to reduce for you? And since you're not having to intubate and re-intubate your patients, well, how many pneumothoraxes and iatrogenic pneumothoraxes are you going to be reducing? So based on all this, you're looking at, even for a 20-bed ICU, you're looking at up to like $1 million annually in savings just by adopting a system that is a replacement for your conventional mobile x-ray, right? Like there's really no advantage, or there's no real change in your workflow. And you know, if you want to be more precise, you can, of course, we've got these sliders here. You can change how many x-rays are happening per your ICU bed. You can change your length of ICU stay. You can play around with what the cost per CT scan is, you know. But these are all based on these references that we found, and they're like averages. So yours may be up or down 10 or 20%, and you can fix those to get something precise. Okay, so let me go back to the financial benefits. Okay, so the other use case that seems to be very interesting is the opportunistic detection of disease. For example, coronary arterial calcium or even nodules. And this data is based on studies that have happened in both the United States and Canada. And the real benefit here is from the opportunistic scan side. First of all, the patient, when we say opportunistic scan, the patient has a problem. It's a real problem and you're fixing it. So this is good news for the patient, and they're going to be grateful that you've helped them resolve it. On the flip side, you've been able to now do some medical procedures in advance, so you have shifted revenue from the future into the present. So that's of course beneficial from a financial perspective. And in this case, let me see, we have a calculator as well. And so say, for example, we're taking a small hospital with maybe 100 beds, and they have an outpatient clinic where you deploy this type of device. What we calculate, and you're located maybe in the United States, let's say Midwest, so it's baseline. Because the prevalence of coronary arterial calcium in North America is roughly over 50% for people aged between 18 and 65. And obviously, the older you are, the higher the chance you have coronary calcium. And coronary calcium is a biomarker because it's going to lead to plaque, which leads to coronary artery disease. So if somebody sees calcium in a chest X-ray, then in general, the next step would be some kind of a cardiac testing pipeline. It could be a calcium scoring CT, it could be a stress test, an echocardiogram, it could be a whole range of these things. So that's really what we're capturing. So we're saying because cardiac disease is so prevalent, and this X-ray is almost like a CT, a non-gated CT at finding coronary arterial calcium, you're going to be able to pick up 4,500 additional patients who have CAC opportunistically, just because they went through your X-ray room. And we have a bunch of assumptions in, okay, how many patients are actually coming into the facility? What is the prevalence of CAC in the general population? We use the American population in this case, so it's the North American population, so it includes Canada, so it's 56%. We've put some numbers for the conventional detection rate of X-ray and the spectral X-ray detection rate, which is much higher. And then obviously, what are the downstream tests? Like, are you doing a stress test? Are you doing echoes? How many of them are being referred for cardiac cath? How many of them are going for implants? How many of them are going for CAC, scoring CT or angios? And then obviously there's reimbursements associated with each of these, and they will vary depending on region. But even something like a small hospital could be generating something on the order of $2.5 million, $2.4 million US annually in incremental revenue because you've been able to identify patients opportunistically. Remember, these are patients who came to the imaging center. Maybe they came for a cough, maybe they came for a cold, maybe they came for something else, and they got an X-ray, and then an opportunistic finding was made. So this one definitely has a lot of potential for helping patients through opportunistic findings, and additionally for the hospital through the revenue that comes along. Okay, so that brings me to the end of the talk. I'm just going to reiterate the benefits. We talked about the main benefits of spectral X-ray as being in the quality, opportunistic findings, and efficiency buckets. Quality because a better imaging, X-ray imaging tool allows you to find problems early, so it can reduce your 30-day readmission rates and non-reimbursed procedures, for example, in the ICU or CCU. It reduces the hospital's exposure to malpractice risk. In terms of opportunistic findings, if you can find disease early, patients who are interested in preventative health, they might be interested. Patients who are just walking in for a cough or a cold, if we can find a real problem, not just an incidental finding, a real opportunistic finding, then that's beneficial for both the patient and the hospital. And then obviously the operating efficiencies that allow us to use our resources effectively so that we're helping the patients in the most effective and timely way possible. And of course, making lives easier for the intensivists, for the radiologists, for the technicians at the same time. All right, well, that concludes the seminar. Thank you so much. Happy to take questions.
Perfect. Thanks, Karim. Yeah, we've got quite a few questions, so I will get going. The first one is, Is any special training required for technologists to start using SpectralDR in daily practice?
Yeah, so the short answer is no, because the clinical techniques are the same. If a technologist is trained in using image acquisition software, for example, by one of the major vendors, it's just a short learning curve, maybe half a day to a day at most, of getting familiar with how to click buttons on a software program. But in general, everything else stays the same. You just get 3 images for every exposure.
Okay, so how is it different from bone suppression software or line enhancement software?
Absolutely. So both bone suppression software and line enhancement software are algorithm-based approaches. And what I mean by that is, like in bone suppression, you look at a chest x-ray, like the one here, and you're going to try and hide, here, I'll swing back to the slide with the bone suppression. I'll swing back to this slide. So what bone suppression really does is it just hides, it identifies the bone by shape and then tries to hide it. The problem with that is if you have a lesion that is sitting right on top of the bone, you're not going to be able to get rid of the, if you get rid of the bone, you get rid of the lesion and you've missed a finding. So, and sometimes the presence of that bone can also lead to additional false positives. And so with spectral X-ray or dual energy, you're actually using the physics of X-ray to identify materials. Line enhancement is nothing more than an edge enhancement sitting on any regular object that has like parallel lines. It's pretty good as well. I'm not going to say it's a bad tool, but it's not going to be able to solve a problem if a line is crossing over the mediastinum, for example, where the X-ray density is going to hide whether that line crosses over or not. You're going to miss the line in those particular situations, but with the bone window where there's a subtraction of the mediastinum, there's more of a chance you're actually going to see the line and the tip.
Okay, so beyond cardiothoracic imaging, are there other areas where SpectralDR's spectral separation could provide clinical value?
Yeah, absolutely. So in general, I say any kind of calcium. You could talk about abdominal calcium if you wanted to find. People have tried to use SpectralDR. They're using it in pelvic X-rays, for example, to see if they can pick up kidney stones. We've got people who, in the past, this is in areas where you don't have CT, they were using spectral X-ray or this type of dual energy X-ray to do IVPs, intravenous pyelograms. So those are at least known use cases of spectral X-ray. And then obviously in space, they were trying to use it for more cardiothoracic stuff. One of the newest areas is on the MSK side. We've had people in different geographies using it very effectively for MSK. And of course, as the bone density measurement starts to kind of become more concrete and it goes through the FDA clearance process, then that will be an interesting option as well.
Okay, so has spectral X-ray been studied with microclip placement?
Not to the best of my knowledge, but that is something that would be very interesting to try.
Okay, and do you use a lower dose with spectral X-ray rather than conventional X-ray for the same procedure?
You can. So this is where I'll go back to the DQE curve. This is an important curve. What this curve is showing you is dose efficiency versus spatial frequency or resolution, if you will. This curve, so the orange line is representative of a conventional detector. So it tells you that the image quality is going to be something for, an RQA5 beam at 2.5 microgray. And for spectral X-ray, you're going to get maybe 20 to 30% higher dose efficiency. What that tells you is, if you want to get an X-ray of the same image quality as a conventional X-ray, you can reduce the dose by 30%. But if you wanted to get higher image quality at the same dose, then you would keep the dose just as you did with the single layer detector, but you would get a higher quality image. So in a sense, it's really up to the site. If they want to get dose reduction and maintain image quality, they can do that with spectral X-ray. Or if they just want to get higher image quality, but maintaining the dose instead, well, you could do that as well.
Okay, so would it provide better imaging for diagnosis for the obese population?
Yeah, so obese population is actually a really interesting use case. The biggest challenge there is scatter of photons, which can end up reducing the image quality in conventional detectors. Also, there's a lot, especially in portables like AP portables, the obese population can be particularly challenging to image. So that's where in the ICU we saw some benefits on the larger size patients, because with spectral X-ray you're doing the subtraction. It helps you visualize soft tissue better. The image I showed you from the ACER study, yeah, this was on an obese patient, right? The portable image is not the best. I mean, it's really hard to see anything. But with this soft tissue image, the so-called soft window, you can see your bilateral cavitations. And so, yes, it does give you an advantage in the obese population.
Perfect. And can you comment also about tomosynthesis with SpectralDR? Sorry, I hope I pronounced that correctly.
No, you said it perfectly, tomosynthesis. Yeah, this is ongoing research work. These panels, the ones I'm talking about, are designed for static imaging, but we do have ones in research and development that are able to acquire multiple images. And so that is an active area of interest for us. So if there's anybody in the audience who is really keen on doing some kind of clinical study with tomosynthesis, we would love to have a conversation.
Perfect. Now, is there a plan to improve IQ by post-processing with AI modules? There seems to be clearly a plethora of potential opportunities for post-processing.
Absolutely. So this is kind of a really important point. AI is obviously the future. We all realize that. The value of this technology is that it's going to make AI that much better, because it's providing the spectral data channel that a conventional X-ray cannot provide. And so the question was, can you improve image quality by using AI? The short answer is, of course. In fact, significantly so, because you have this additional spectral data. And so in some of the new imaging products that we are looking to bring out, we're incorporating AI to do even highlighting specific materials, doing multi-material decompositions, and so on and so forth. So yes, there's a lot of opportunity, because the spectral X-ray really is a platform. It's a platform in the sense that if you have a spectral X-ray, there's really no need to have a conventional X-ray anymore, because you're already getting your conventional X-ray, but you're getting so much more. So this is kind of, in a sense, the future of X-ray, if you will. Just like black and white cameras were replaced by color cameras, and black and white television was replaced by color television, black and white X-ray will be replaced by spectral or color X-ray. This is kind of what we think is going to be happening in the future.
Perfect. And I've got now a question about your financial modeling. Is it available on your website?
Yes, I think you have to get a hold of us. I think there's a request form for it, but yes, we can get you access if someone's interested.
Yes, perfect. Okay. Well, before we wrap up, Karim, is there anything you'd quite like to summarize, or have you got a top tip to share?
No, I'm really happy that we had this opportunity to do this. RSNA is around the corner. The ICE conference is around the corner. We're going to be at these shows. Please come and talk to us and see spectral X-ray in action.
Perfect. Well, as we're coming up to our hour, thank you so much, Karim, for your time today and for a fantastic presentation. Thank you. And we'd also like to thank KA Imaging. If you'd like to visit kaimaging.com for more information, I'm sure they'd love to hear from you. As promised, the answer to today's trivia question is pink, so congratulations to our winner, Sherry McDavid. Now, just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 ARRT Category A CE credit by the AHRA, and you'll be able to download the certificate directly from your computer once you've submitted the survey. Now, if you have any questions, you can reach us at webinar@mdpublishing.com. Please visit icewebinars.live for more details of all our upcoming ICE webinars and, of course, complimentary registration. Now, if you've missed any of our past ICE webinars, including any by KA Imaging, please visit icewebinars.live to view our whole webinar archive. So thank you all once again for your time today, and I hope you enjoy the rest of your day.